Our next presenter is Dr. Ray, who will be presenting Ventral Hernia Repair in Contaminated Fields, a survey to identify current surgical practices.
All right. I'd like to thank SAGES for this opportunity to present. Good morning. Where is it just clicking?
You can do that or this if you like.
Oh, okay, great. I have nothing to disclose. Ventral hernia repairs are one of the most common surgeries performed by surgeons worldwide. Wound infections after ventral hernia repair are somewhat common and greatly increase the risk of recurrence. SAGES has established guidelines for ventral hernia repair, and points related to surgery in contaminated fields include recommendations that laparoscopy leads to fewer surgical site infections, and methods of salvaging infected prosthetic mesh before excision are listed. The objective of this study was to evaluate how experienced hernia surgeons treat ventral hernia repairs in the setting of contaminated fields, and also assess how this management aligns with currently available data and guidelines on ventral hernia repair. A survey was created by two expert hernia surgeons, one from the US and one from Europe. The survey uses clinical vignettes to assess surgeon practices. The survey was an anonymous internet-based survey distributed through the RedCap Data Capture software program, and it was open from January 2013 to January 2015. Responses to questions of the survey related to ventral hernia repair in contaminated fields were analyzed to identify practice patterns. So this is an example of a clinical vignette in the survey. This specific question asks about which mesh type or primary repair would be used to treat a greater than 6 centimeter ventral hernia in a contaminated field. This follow-up question asks about treating a recurrence in a now clean field. And this question asks about a recurrence in a field that is still contaminated. You see that your choices are permanent synthetic mesh, absorbable synthetic mesh, biologic mesh, or primary repair. The survey has an overall response rate from the two hernia societies that we sent this to of approximately 13%. The majority of respondents were male, aged 46 to 55, in practice for greater than 20 years, and performed greater than 25 ventral hernia repairs annually. The percentage of surgeons performing laparoscopic ventral hernia repair was higher in respondents from the US compared to the European subgroups. In working up and preparing patients for surgery or prehabilitation, there were some differences between the two groups. Respondents from the US were more likely to initiate tobacco cessation and check and advise control of diabetes prior to surgery compared to the European subgroup. Approximately 2/3 of both groups recommended weight loss programs for surgery for obese patients. When asked about how surgeons would manage ventral hernia repair in contaminated fields, most preferred either biologic or permanent synthetic mesh, and only a minority would repair the hernia using primary repair or absorbable synthetic mesh. When looking at the European and United States subgroups, respondents from the US preferred biologic mesh, whereas respondents from Europe preferred permanent synthetic mesh for ventral hernia repair in contaminated fields. When asked about ventral hernia repair near a stoma, more European respondents preferred permanent synthetic mesh. Surgeons would treat a patient with prior MRSA wound infection in the same manner as that near a stoma in both groups, with similar proportions responding in each group. There were a few knowledge-based questions in the survey. A described clean contaminated surgical field was identified by 73% of respondents. 52% identified a suture length to wound a ratio of less than 4:1 as a risk factor for surgical site infection, and 17% identified a 32% risk of recurrence after underlay mesh repair for a ventral hernia at 10-year follow-up. Practice patterns described earlier did not significantly change for respondents that answered these questions correctly. So there is significant variation in how ventral hernias are treated in the setting of contaminated fields in terms of preparing patients for surgery, selection of mesh for repair, and also management of ventral hernia in patients with stomas or those with prior MRSA wound infections. These practices differed between respondents from the US compared to European respondents, and these patterns were independent of correct answers on knowledge-based questions, suggesting practice patterns may be dependent on other factors, such as financial factors. I'd like to acknowledge the following people for help with this study. Thank you for your time.
Thank you. Questions? So I have a couple questions for you.
Sure.
So I guess in the general conclusion of this, have you shown that we're just so confused about what to do in this scenario that there's very little clarity, or have you kind of shown general trends in what we ought to be doing?
So I think one of the main things is, yes, there is great variability. I think that's one of the main conclusions. I think one thing that this brings up is kind of, what should we be doing to help disseminate new findings and guidelines so that people are following them. Another thing that I think it brings up is trends that are different in different parts of the world, and exactly why those are different, I think would be, I would have to just come up with theories that, it'd be theories at this point. I don't know exactly why, maybe because of reimbursement patterns or just cultural differences in surgery.
So to kind of follow up on that, so is it just that these groups are kind of so different and subtle things that these numbers actually show fairly good agreement that we agree on at least 40% of what we would do, and that the fact is these patients are different, these wounds are different, these techniques are different, these meshes are a little different, that we're never going to get to where we can say, okay, for this wound, everybody out there is going to agree upon what to do? Is that just false hope on what we should be striving for?
I don't think that you'll have everyone doing exactly the same repair for the exact same patient, especially given the current literature. But I think it is important that facts that are confirmed with large randomized control trials or really, really large studies from some of the national registries in Europe, that when something is definitively known, that be disseminated, and at least those factors that everyone should be practicing those practices that are well known.
So in your study, the majority of your respondents had been in practice over 20 years. So do you think disseminating these guidelines will change practice?
Yeah, and that's actually an interesting question. When we looked at the knowledge-based questions, some of which were in more recent data, and you've filtered out people from both subgroups that had answered all of those questions correctly, those respondents were generally younger and earlier in their practice. So I think you bring up a good point in that maybe surgeons younger in their practice are more open to changing practices or open to new findings in the literature. So I think there may be a gap in implementation.
Thank you. I think we're out of time.
Okay, listen, everybody, all the presenters, I think you guys did a great job. I think this was a great session. Thank you all for those great talks and great discussion. This will conclude this session. Thank you very much.